All right. Analyzing cardiac rhythms, VFib, VTAC, asystole, and pulseless electrical activity. VFib is a disorganized cardiac rhythm that produces no pulse or cardiac output. Associated with advanced coronary artery disease, 50 and 60% of cardiac arrests are in VFib during the first 8 minutes after becoming pulseless. VTAC, rapid heart rhythm generated in the ventricle. The rapid rate reduces cardiac output because the time for the ventricle to refill is reduced. Can degenerate into VFib. An AED responds to VTAC when the rate is greater than 180. Since some VTAC patients remain aware, an AED is applied only to unresponsive pulseless apneic patients. Asystole, that's absence of electrical activity or a flat line. Beep. No pumping action of the cardiac or cardiac output. Chances of resuscitation are not good. Defibrillation is not appropriate. PEA or pulseless electrical activity. The electrical activity appears organized, but there is no cardiac output. Defibrillation is not appropriate. Said it earlier, read your patient and not your equipment, because if you're looking and you see an electrical rhythm but there is no mechanical pulse behind it, meaning you didn't check a pulse. I mean, the patient's heart's not beating, but it appears to be on the cardiac monitor. So always look at the patient as well as your equipment, and not just your equipment. Alright, VFib is associated with chaotic electrical discharge in the ventricles. So ventricles are doing what they want, just shooting blah 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 blah. Chaotic electrical discharge, as seen on the ECG tracing here. Just a chaotic rhythm. VTAC looks a little bit more organized. This is a rhythm strip of VTAC here at the bottom. VTAC can have a pulse and it can be pulseless. Alright, asystole is flatline, meaning the heart's not doing anything mechanically or electrically. This is the worst rhythm a patient could end up in. Alright, analysis of cardiac rhythms. No one should touch a patient during AED rhythm analysis or shock delivery. Movement interferes with the rhythm analysis. The electrical energy can be transferred to anyone touching the patient. So make sure your partners are clear, because we don't want to have 2 patients instead of 1 patient. Make sure we're pretty dramatic when we say all clear. People throw their hands up, they jump back, but that's good, because you can inadvertently have an arm on them, a knee on them, anything touching them, and that electrical current could be passed through your body. So let's be careful when we're doing this stuff, and also trying our best not to touch the patient or move them around a lot when the AED is analyzing that rhythm. When and when not to use the AED. Okay, AEDs can be used in patients of all ages. Manual defibrillations, defibrillation is preferred for those less than 1 year old. A dose attenuating system is preferred for use in children. Use adult pads with children greater than 8 years of age. Alright, children 1 to 8, when we first started dealing with AEDs, they tried to have pediatric pads and adult pads inside of the AEDs. Now, more so, you don't see the pediatric pads. Okay, so most defibrillators are pretty smart, and even with children 1 to 8, you can still use the adult pads. So don't think because you don't see pediatric pads inside of an AED you can't use it. You can still use it on children 1 to 8. Alright, assessment-based approach for cardiac arrest. Scene size up in primary assessment. If a patient appears unresponsive without signs of life, quickly check for breathing and a carotid pulse. Assess no longer than 10 seconds. If the patient is apneic or has agonal respirations, begin CPR with a CAB approach. CAB stands for circulation, chest compressions, airway, and breathing, which is ventilation. You want to check that pulse and you can look at the chest at the same time. Like I said, the quicker we start CPR, the better, so you're not wanting to waste time when you're doing this. You want to do it pretty quickly. With a lack of interruptions once you start. Patients less than 1 year of age, if the heart rate is less than 60 with inadequate ventilation, assist or provide ventilations at 12 to 20 per minute. If the heart rate is, if the heart rate is greater than 60 with inadequate ventilations, just assist with ventilations at 12 to 20 a minute. If the heart rate is less than 60 or the pulse is absent, begin chest compressions immediately. Patients less than 1 year of age, 30 compressions, 2 ventilations for 1 EMT performing CPR. And we do a 15 to 2 ratio for 2 EMTs performing CPR. The big thing with that is, especially if you're using a bag valve mask, a BVM, it's really hard for to get a good seal. So you're going to take more time trying to do that, opposed to you got 2 people there, one doing good compressions and the other one focused only on creating a good seal and doing ventilation. So that's where your differences come in at with when you have 2, the 30 to 2 versus the 15 to 2. Alright, patients 1 year of age to puberty, 30 compressions, 2 ventilations for 1 person, 15 to 2 for 2. Adolescents with signs of that they've hit puberty, and adults. It's 30 compressions to 2 ventilations, rate of at least 100. Compression depth is at least 2 inches. For an obvious pregnant patient, displace the uterus laterally. Alright, in your secondary assessment, you want to attempt to obtain a history from bystanders or relatives, but do not interrupt chest compressions or delay defibrillation. Signs and symptoms of cardiac arrest are as following: unresponsive, no breathing or apnea, or normal breathing, gasping type, or abnormal breathing, gasping type, or agonal ventilations. No pulse. Pulse should be checked simultaneous with breathing for no less than 5 seconds, no more than 10 seconds, and no other forms of life. Alright, assessment-based approach, cardiac arrest. Emergency medical care, continue CPR and defibrillation as indicated. Reassessment, once perfusion is restored, continue to reassess. Patients may revert to cardiac arrest. Alright, CPR and defibrillation are performed to restore the patient's pulse and perfusion. After the pulse is restored, continue to perform reassessments en route to the hospital. As discussed in the following sections, a patient whose pulse has been restored may revert into cardiac arrest. So the reassessment is focused especially on monitoring the patient's pulse and breathing and mental status. Alright, perform defibrillation using an AED. Ideally, at least 2 EMTs are present. Take standard precautions. This normally should be done en route to the scene. Perform a brief primary assessment of the patient. If the patient is unresponsive, apneic, and has agonal ventilations, has no pulse, and has no other signs of life, immediately initiate CPR. Begin with chest compressions. Use CAB intervention sequence. If someone witnessed the cardiac arrest and the AED is available, immediately apply the AED. If no one witnessed the cardiac arrest, immediately begin CPR and then apply the AED as soon as it is available while chest compressions are being performed. Perform AED operations from the patient's side to minimize any interruptions in chest compressions. Turn on the power to the AED. That's a big question. A lot of times they ask what is the first thing you do when operating the AED. Some people say put the pads on. Nope, turn the power on, because someone will tell you exactly what to do once you turn the power on. Continue chest compressions while attaching the adhesive monitoring defibrillation pads. Minimize any interruptions to chest compressions. And following the manufacturer's instructions for applying the pads, turning on the power, and pad placement. There are 2 different AED pad placement options. Anterior lateral placement. One pad is placed on the right side of the anterior chest directly below the right clavicle, and the other pad is placed on the left lateral chest. Anterior posterior placement. One pad is placed on the left anterior chest just below the left nipple, and the other pad is placed on the left posterior thorax just below the lower margin. They most of the time have pictures show you exactly where you need to put those pads. So alright, next is going to analyze the rhythm and defibrillate as recommended by the AED. Alright, use of the AED by a single EMT. Simultaneously verify that the patient is unresponsive with no breathing and no pulse. Call for additional EMS and the AED. Immediately begin chest compressions and apply the AED as soon as it is available. Minimize your interruptions and compressions. A pregnant patient in cardiac arrest. Alright, for pregnant patients in cardiac arrest who is at 20 weeks of gestation or greater, it's necessary to place the patient in the supine position and to manually displace the uterus off the vena cava when doing chest compressions. Most often due to hemorrhage, cardiovascular disease, or amniotic fluid embolus, sepsis, aspiration pneumonitis, pulmonary embolism, or eclampsia. For a patient 20 weeks of gestation, it's necessary to place the patient in the supine position, like I just said a little bit earlier. To achieve this, a maneuver referred to as lateral uterine displacement, or LUD, manual LUD during resuscitation can be performed by using one of the following techniques. The one-handed technique: position yourself on the right side of the patient. Take your extended right hand and place it in the lateral aspect of the abdominal at and just below the umbilicus, and manually push the uterus to the left. A two-handed technique: position yourself on the left side of the patient. Take both your hands and place them on the right lateral aspect of the abdominal with the hands extended and clasped, and the tips of your fingers are both hands touching, forming a sort of cradle with the umbilicus in the center, and manually pull the uterus towards you to the left side. You must Perform and maintain LUD or LUD during the entire time the patient is in cardiac arrest and chest compressions are being performed. If a pulse returns and chest compressions are no longer needed, the right hip can be elevated to take the weight off the inferior vena cava. Alright, transporting a cardiac arrest patient. After emergency care procedures and operations of AED, if ALS is not responding to the scene, transport. The patient regains a pulse. Your protocols indicate transport after a prescribed number of shocks or no shock indicated message. Alright, transporting a patient with a pulse. Provide oxygen ventilation as needed. Have suction ready. Transfer the patient to the ambulance. Consider getting ACLS to the patient. Keep AED attached. Perform secondary assessment and reassess every 5 minutes. Alright, we want to provide just enough oxygen to achieve and maintain an SpO2 of 94% or greater. Because many cardiac arrest patients vomit, always have the suction right there on hand. And never take the patient off the AED simply because what if they go back into cardiac arrest, or better yet, they go back into AFib. If you don't have the AED hooked up, then you have no way to shock them again. So make sure to leave all that stuff hooked up. Very important to continue to assess the patients just in case they decide to deteriorate again. Transporting the patient without a pulse. Continuing to do CPR and defibrillate. Follow your protocol. Use extreme caution when defibrillating in the ambulance because you're working with a small amount of space. And rendezvous with ALS as early as possible. Post-resuscitation care. Indications that ROSC has occurred. A pulse is felt after the AED indicates a no shock advisory. Patient regains spontaneous breathing. The patient begins to move. Upon ROSC, assess the patient's ventilation. Avoid potential oxygen toxicity issues. An adult patient should be ventilated at a rate of 10 to 12 per minute, and the child or pediatric at 12 to 20 per minute. Excessive ventilation can reduce cardiac output and cerebral perfusion. So let's be careful not to overventilate. Alright. Providing for advanced cardiac life support. The AHA 2015 Chain of Survival advocates for advanced cardiac life support. Minimize the time from delivery of CPR and defibrillation to the arrival of ACLS. Alright, and we are to our summary. Alright, review assessment findings that may be associated with cardiac arrest and emergency care of cardiac arrest. Assessment summary. For cardiac arrest, the following are findings that indicate cardiac arrest. Patient is unresponsive, apneic, or pulseless. Safety considerations. Make sure everyone is clear from the patient before delivering the shock. Do not defibrillate a patient who is wet. Use caution defibrillating on metal surfaces. Remove transdermal medication patches on the chest. Remove excessive chest hair. Alright, this is just maintenance for AED. Do not place AED pads directly over a pacemaker. Normally a little lump felt in the chest. Very important. If you do feel a little lump under the skin, it may be a pacemaker, so be careful not to place those AED pads directly over those. Alright, just a couple special considerations. Automatic implanted Cardioverter defibrillators detect rhythm disturbances and deliver shock. Do not place AED pads over the ICD. If the ICD is operating, allow 30 to 60 seconds for it to complete its cycle before attaching the AED. This is auto posts, which are very handy dandy and nice to have. Alright, shock is critical condition related to decrease in vascular volume, poor cardiac function, or vessel disturbances. Shock results in a shift from anaerobic cell metabolism, a shift to anaerobic cell metabolism. Shock management focuses on airway, ventilation, oxygenation, circulation, and rapid transport. Remember, guys, guns don't kill people. Shock does. And cardiac arrest. Alright, chain of survival, immediate recognition and activation, early CPR, rapid defibrillation, effective ACLS, integrated post-cardiac arrest care. And thank you guys for hanging in there with me. I hope you guys got a little something out of this, and hopefully the more I do it, the better I'll get. Alright, maybe I'll see you in person sometime. Have a good one.